this session is really about what do they feel? What do they see in the exam room? What are they living? What works for them? What doesn't work for them? So the way I'd like to start it is to just go down the row, have every doctor give a brief background as to your specialty, your practice setting, your experience with EHRs, who you're using today, so the audience gets a feel for when you're answering a question, you're answering from what context. So Dr. Bill, I'll go with you first. We'll just go right down.
I'm Bill Levin. I am actually, I think it says in the program director, I'm associate director of the Penn Radiation Oncology Network. We currently have 7 off-campus facilities with various relationships to hospitals versus some of them we are freestanding, fully owned. So we have many levels of complexity in terms of our EHR, both in terms of being a Penn facility, but also in terms of interacting with firewalls and HIPAA kind of considerations at the other sites. I treat cancer patients, essentially, so it's a little different approach, and utilization is probably some of my colleagues. Happy to answer any questions for you.
I'm Mike Smith. I'm the medical director of the Temple Esophageal program up the street at Temple University Hospital. I've been there since 2008. I was at Penn for about 8 years in the late 90s, early 2000s, and was there for the rollout of EPIC in the outpatient clinic setting, and then was up at Columbia Presbyterian Hospital using a limited EHR that they had that was their own system called WebSys, and then back at Temple now almost 5 years, and was there for the rollout of EPIC about 2 years ago.
I'm Bob Norris. I'm a cardiologist at Pennsylvania Hospital. I'm the section chief in cardiology. I've been at Pennsylvania Hospital for embarrassingly 23 years. I do invasive cardiology. I spend a lot of time in the office, also spend time in the hospital. My practice has been a private practice until March of this year, and we've worked on Greenway, and our practice was recently purchased by the University of Pennsylvania. So we are going to be transitioning to EPIC in 2 months.
Good luck. I'm Sal Volpe. I'm a dad with 2 kids and chief medical officer at PDR. Been in practice 25 years, more or less, using electronic health records for about a decade. Worked with Farzad and Matt in New York City with the first regional extension center at the time. And just looking forward to spreading the word.
And you used, I'm sorry, I didn't hear you.
I used, I'm familiar with eClinicalWorks and several other products.
So we've got eClinicalWorks, Greenway, moving to EPIC, EPIC, and EPIC. All right, so we'll hear what they think and what they don't think. So I found these 2 studies interesting, and in essence it says, I don't really know what physicians like and don't like about EHRs, because as you can see, in one survey, they were pretty satisfied, and then just recently, their satisfaction levels went south. So why don't we start with Sal and work our way back. What do you like about eClinicalWorks? What don't you like? What's missing? Greatest hits, and then then we'll just keep moving down.
Sure.
Go ahead, Sal.
With eClinicalWorks, as an internist geriatrician, the best is doing refills. The average patient in my panel's got at least 5 meds. So having to do that manually is very onerous. The ability just to be able to push forward their lab results to the portal has been very, very helpful because it leads to greater discussion on their care. The ability to document, once you get the hang of what you want in the note, it becomes pretty quick and easy to pull general notes up. And the ability to hand out office visits, we hand them out at the end of each visit for the past 10 years. It has helped our patients who've had to go to the ER, or when we have a lot of snowbirds who go down south. So it's helped them there too.
What I've liked about working on an EMR is the ability to categorize and put together information on my most complex patients. It helps prevent me from losing important things, and really helps organize the information on a complex patient. The other thing I've liked about my particular EMR is the billing. The things I don't like about EMRs are, I really think that we're kind of in the, I'm probably going to not make everybody in the audience happy. I really feel like we're in the practice stage with EMRs, that they're very imperfect, at least the one I work on, and that my own opinion is that they slow us down, particularly with patients that we would be quick with. Somebody that's here for a wound check, or somebody who's here to just adjust a hypertension medication. What could be done really quickly on paper, at least with the EMR I've worked with and others I'm familiar with, it just becomes, makes a patient visit a big to-do. The other thing I don't like, at least currently, at least in the EMR world I'm in, is I feel like I'm in a silo. It's not integrated with anything. Even though I work at Penn, it's not integrated with my hospital, it's not integrated with my ER, it's not integrated with physicians one floor above me, one floor below me. It's not integrated with my echo reports, my nuclear report, my EKGs. Even though the vendor told us that would be really easy to do, it turns out the only thing it's really integrated well with is the scanner.
So on that, is the integration an EHR issue or an IT issue with your hospital system?
It's both.
Okay, so we're
Partly
just
'cause
giving credit
we're
to-
small, they're big, but part of it's a cost issue. Yeah, we can do that, but it's more expensive than we thought.
And that expense, who's making that call? Your practice or the hospital?
The EMR company as well.
Okay, fine. Michael?
So I guess there's hope for Bob in that, having been on Epic for a while, with time the integration gets better, and I can see the notes from the oncologist above me, the pulmonologist 2 floors above me, and from other folks throughout the hospital. The inpatient, outpatient piece comes with time, but there's certainly a significant cost to that. And I think I would echo what both of you have said, and the integration piece, bringing in endoscopy reports on a gastroenterologist into having that into the Epic record took some time and was an IT and a cost issue, being able for one to feed the other. It's still frustrating to me that down the street, where patients who go between my hospitals and 1.5, 2 miles apart are, I still don't know what the colonoscopy for the rectal bleeding 2 miles down the street 2 weeks ago showed, and now I have to repeat the procedure, which makes a lot more cost and time to the system, is still very frustrating to me. And while I love being able to organize prescriptions and have them be relatively coherent between different folks within the Temple system, if there's a private doc who referred in, I often can't get access to that, and that's frustrating to me. In terms of being able to organize and really know what a patient is taking when they walk into my office. So that's a real important piece of it too. But I think it's just a very slow-moving creature, and there are little improvements and here and there. But as it gets bigger, it gets more cumbersome too, and you wonder what really can help you, and what's just going to slow you down further.
So let's stick with your colonoscopy patient, because that's something that we all hold near and dear to our hearts.
Wait, there are some young enough people in the audience. They're not due yet.
So when we all had paper, well, I didn't have, but when you had a paper system, those records were apart. So now that you have electronic health records, is there an expectation that they'd be talking together? Because with paper records, you'd run into the same issue.
100%. I think the scanner piece is a very important issue here. And that, yes, we fax copies as a backup to folks even within the Temple system to make sure that they get a copy. And then when I go search the media tab, I see 7 copies of the colonoscopy report that are all filed by each of the different doctors that scanned it in. So it takes forever to look through to see, what are the, what other reports that are in that tab, or how else do I find additional information? And every time somebody touches the patient, something else pops up, and the records get to be interminably long to try and search to figure out what's really going on. So there's a very low signal to noise ratio in that respect too.
Bill, as an oncologist, EHR, like, dislike, what works?
So I don't know that it's much different than these guys, but certainly the management of the cancer patient is really intertwined with other specialties. I do radiation, and we absolutely need to interact with the surgeons and the medical oncologists. So certainly, I would say the majority of the patients at Penn, I'm seeing patients at the main campus. I would say the majority of patients that I see day to day have their care completely in the Penn system. And for us, at this point, at the main campus, that integration is quite good. Everyone is on Epic now. Now, the surgeons have typically been the slowest, and they dupe you. You see, oh, the surgeon put a note in an Epic. You go click on it, it says note dictated, and you can't find it. But even they're getting on board now. You know, on the most basic level, I have a note from someone, and now I can read it, which is a huge difference than getting typically a note from the surgeons, which is a very different type of note than the oncologists write. That's good. In terms of the bad, the biggest one for me, which is a common cry throughout the hospital, is I never learned how to type. I got kicked out of typing class in high school, so I'm paying for it now. A lot of the docs, typically the older ones, I see that they have somehow got the department to spend $3,000 on a Dragon license for them, and then probably another $1,000 for the microphone. I don't have the guts to ask for that right now. But honestly, if I could dictate the way I dictated a couple years ago with the tape recorder, I would do it in a second if I knew that it was going to work. And also the idea of spending time teaching Dragon my voice and so forth, I just get tired just thinking of that time investment. But certainly that's one thing that a lot of people would like to see on the most basic level. In terms of what I do day to day, something that you guys that will be more applicable to most of you in the audience, I tend not to use the e-prescribe tab in Epic very much, because so far I think I have about a 50% success rate of that script being filled. Half the time I'm getting calls from my administrative assistant, or I'm getting calls from the pharmacy. Mrs. Jones is here, there's no script. I actually even had difficulty with the outpatient pharmacy at Penn across the street filling an order for Ensure Boost the other day. So the e-prescribe tab has been a problem for me. The other thing that I would like to see, I made a couple notes when Rich and I talked the other day, is the way that that Epic specifically is set up. It's good for a single encounter. But what I like to do, and I know what other physicians like to do, it would be nice to be able to kind of look at your current census of who's on your service right now. And I personally, in terms of when I design my radiation treatments, I may remember there was a patient that I treated about 6 months ago with a lung cancer who also had a pacemaker that I was trying to stay away from, and I would like to go back and check the technical notes. So I would like to see a better way to kind of look at my entire population of people, say for a given time period or by a given diagnosis. I don't think that it's very user-friendly in that regard. The other thing that I would say is that again, I've been on Epic since probably 2008, and it's just not intuitive. The best thing that I could say about having to learn the EHR at Penn is that you have residents, and they're the young ones, and they're the ones that understand how those things work. They're the ones that type incredibly well. But honestly, that's how we've learned. Most of us have learned the EHR from the residents. You know, the half day that they give you to learn Epic doesn't mean anything. Your head's spinning. You don't remember anything from that. So I would like to have a way where you can actually kind of get to where you're going, to see it look more like a Windows sort of interface or an Apple interface.
The good old resident, that's good. So let me jump back to one point you made on the e-prescribing. You said 50% are not getting filled. Is that an IT issue, or is it a formulary issue, or is it a callback? I mean, or is it just not showing up at the drugstore?
Yeah, I actually, personally, I don't care because I'm running all day long, and I just get on the phone to the pharmacist and fill it. But yeah, I know that they say it's not here. But on my end, it's certainly, and then I always get the nurse to verify that I was doing the right thing.
Or the resident.
Or the resident, and you can see it. It looks like it's been filled on my end, so I can't tell you beyond that where the problem is.
In my X number of years dealing with electronic health records, that's the first time I heard something like that. We talked earlier in the day and periodically throughout the sessions on usability. And usability talks about when the system goes on, how usable is it? If you look at this slide, Epic and CERN, or Epic, I should say, was very usable. And then 81% usability. So the green means 81% usability when the doc got on it. And then within 2.3 years afterwards, 90% usability. So let's go to the Epic guys first. And Mike, we'll start with you. And you started on Epic at Penn, and then you went to Temple. So why don't you talk about both? Mike started at Penn and went to Temple. In both cases, Epic.
Right.
What about your usability? What was the difference? And why don't you share that a little bit with the group?
Well, I was a resident the first time, so I guess I was teaching my attending physicians back then in 2000, and I guess that would have been 2002 for the rollout at the Penn clinics. And I think being someone who grew up in an era where I was using a personal computer at home in high school and college, in medical school, that was an easier transition for me in terms of usability. But it made sense intuitively to look at it and sort of look at the organization and think about it. What I found now, having had more time in clinical practice, between the rollout as a resident and then now as an attending, sort of setting the pace rather than being told what to do as a trainee, was that the organization now as I take care of a patient is very different than the way that the visit is organized by the EHR. And that the order that I would ask the questions and obtain the information from the patient doesn't align with the way that I can most optimally get through a visit in the shortest amount of time to complete the visit, to check all the boxes, to be able to close the encounter. And I think that I recognize I was sort of younger and more malleable in the first iteration, so I was able to go with the flow better. And now that I've sort of become a little more set in how I'd like to take care of the patient, I now find myself trying to conform to the EHR to be able to do what I need to do to complete meaningful use.
And
that's a big difference.
I've heard that before. Sometimes, especially with Epic, my other doctor friends say you have to conform how you practice in your workflow to work within the confines of Epic.
It takes me 10 to 15 minutes before I get to say to the patient, so what brings you in to see me today?
Bill,
They look at you like you're crazy.
Bill, what do you think? Usability with Epic when you got going?
It's very difficult. If you didn't know the next step, you were dead in the water. So, now I'm pretty sure if I get to a point, if I don't know it, it's more obvious to me. That doesn't mean that I can intuit the next step, but I kind of know when to ask for help. The other thing I failed to mention that I do like with Epic is the smart phrasing and the templates. So that does help someone like me who can't type. So.
Usability when you started with Greenway.
It was challenging. I think a lot of people don't learn from just sitting in a talk. You really have to use it. And there was supposed to be this playpen that we could practice in with practice patients. And for some reason it didn't work. And knowing who I was, that I wasn't going to learn just from listening to talks, I actually started to put patients in in Greenway before we were really using it. And my office manager was not thrilled with that. But, that was the way I learned. I didn't want to learn in front of patients. And I think the learning curve in our practice in Greenway was actually pretty steep once we figured out exactly what parts of it we wanted to use and which parts we didn't. There were templates that we were told were going to be really helpful to us that we learned pretty quickly were not helpful at all. What I can say is that I know that I could type 25 words a minute before I went on an EMR because I took an online typing test kind of randomly. So recently, after 1 year of being on an EMR, I said to myself, wait a minute, I need to take another typing test. This could be kind of cool. And I can now type 35 words a minute, probably about the same error rate. So I have gotten something out of being on an EMR.
And Sal, your usability with eClinicalWorks?
Well, I got to say at the onset, though, advantages for me versus the three on my right are, one, I got to go through 20 different EHRs, visiting users, visiting conventions, brought my office manager, vetted the product that fit my workflow versus me trying to fit its workflow. So that was one advantage. Two, we took 4 days worth of training. Closed down the shop, literally. 4 days, 2 days without patients. Last 2 days, 1 patient per hour, which a large organization probably would not tolerate, but my wife and kids and the lack of vacations did. So it's a financial investment, and it's something that I think a large organization and small organizations have to acknowledge. You're the primary inputter of information. If they don't train you adequately or give you a chance to learn, then that creates the bottlenecks that we saw in the previous presentations. E-scripts don't go out, and we don't even know why. I mean, it seems absurd. So in the beginning, I figured I got about 25% usability at the EHR. My first week or 2 or 3, I was writing a bare bones acute care visit. I wasn't going in past medical history. I wasn't backfilling a lot of stuff. I was just learning how to do the simples. How do you get your vitals and review them? The medical assistant got the vitals. Did I know where they were? And could I do a trend just by looking at it? Could I do a routine physical? And could I get an assessment and a plan? It took many weeks afterwards to build a note, which now I think is really robust. And I think I'm up to like 90%. I would not pretend to say 100% use of that EHR. There are still little icons in there that I just don't want to touch for fear that I'll maybe blow something up somewhere far away. It's not a good joke to make right now at this point. But there are just things in the system that I don't even deal with because, quite frankly, I don't need them. I seem to be able to take care of patients pretty well.
So I heard a common theme here, which leads into another set of questions. Michael said it took me 10 minutes to get to the patients, to get through the system before I got to the patients. Bob said, and I wrote this down, I don't want to learn in front of the patients. Dr. Golub said earlier there was some challenge with patient relationships, and then when I was getting prepared for this, there was an article I read in Healthcare Tech Review that talked about the biggest reason providers saw negative results when they started using EHRs was the damaged doctor-patient relationship. Doctors claim less eye contact with their patients. So I think I'm going to get nodding heads and we'll fly through this one. But what's your experience been? And you probably got, Bill, the most important relationships with your patients in the eye contact. Has it impacted you? And we'll just quickly run down the crew again.
Yeah, so today, Wednesdays, is the day that I see all my patients on treatment who are getting radiation treatment. That's the only thing that's scheduled for Wednesdays. Because I'm not, as I keep saying, with the typing and just the manipulation of the system, I review, so while the nurse or resident is in the room, I review the record of what happened last week. I look at any new studies and so forth. I rarely look, so at Penn, in each exam room, there is a monitor, and the nurses, the way they're instructed is basically to have the Epic encounter open for you in the room. I almost never look at it in the room for that reason. I know that I can, between the doc's workroom and being with the patient, I know what I need to know. The only time I may do it is to double check on a dose of something, or if a patient asks me, say, for a script. But other than that, to me, I've decided for that reason, for that relationship, it's just too detrimental. And if you're not looking at someone, that really compromises your relationship. And when we treat patients for radiation, I may see that patient weekly for 7 weeks. And if you start off not looking at them, that's a rocky road. So I essentially try to avoid any entry while I'm with the patient.
Mike?
I have 2 key relationships in my practice. Number 1 with the patients, and number 2, I have a fully referral practice, so the referring gastroenterologists who send folks with esophageal problems that need a higher level of care than they can provide out in the community. I start every office visit with, I'm really sorry, but I have to type everything into the computer, so I apologize if I don't spend as much time looking at you and paying attention to you. I really am, but I want to make sure I get everything right in the computer. So everything starts with an apology from every patient. And the other thing is
So wait a sec, you start with an apology and you start with a resident, right?
If I have a resident.
If you have a resident.
I haven't gotten his seniority yet. I don't have the resident in every office visit. But the other person, frankly, that I have to be responsible for in terms of the quality of the contact is the referring physician. And so actually, I don't close any of my encounters at the time that I see the patient, and it drives my administrator nuts And I end up it drives my family nuts because I spend nights and weekends cleaning up the notes to make sure that they are presentable and high quality to go out back to the referring physician so that my referral stream continues. Because if I send the shorthand that I could type in an EHR to get the visit done in a timely manner, I'd never get a patient back again if that other doc reads that piece of crap and says, what's he doing with the patient that I sent him for? Why, I should be getting something more coherent.
Shorthand typed notes will not make sense to the referring physician.
It looks like you didn't spend any time with the patient. And if you try and use the HPI, the history of present illness that's in there, I get them from other docs who do it, and I have no idea what they did for the patient and what was going on. And so I end up hand typing the present history of present illness for the patient because I want it to make sense to myself, both when I decide if I'm going to treat that patient for pre-cancer or cancer of the esophagus, or how I'm going to decide how to help them swallow again. I've got to give myself and the referring doc some kind of quality documentation that I know what I'm talking about with that patient case, otherwise they get lost. And so I have to fix the EHR to make it look like reasonable, good quality physician communication.
Bob, you're nodding your head, so just keep going right on.
Yeah, I agree with that a lot. What the referring physician gets, that's the product that they receive from us. My own workflow, which stemmed a little bit from starting on an EMR and again being a little bit of a silo, is I actually start my charting before I go in the room with the patient. So I finish with one patient, and then in a little room that I have that's near the exam rooms, I will open up the patient, review my last note. If it's a new patient, I might actually go into MedView where I can see Epic, where a lot of the referrings are. I may cut and paste in a legal fashion some of the information from there to start my note. I might get labs off. Again, I have to get them off another computer, so that I want to have all the information before I go in the room, so I'm not doing that in front of the patient. So I will create a lot of my note, and I'll type the HPI in front of the patient, and then when I'm done with the patient, in many cases, not all, I do exactly what Mike said. I actually will do my assessment and plan just before seeing the next patient, or sometimes I'll do it later in the day, because if it is going to a valuable referring, I actually want to put a couple of smart thoughts onto the chart. I don't want my note to look like some of the notes I receive from other doctors on EMRs, where all I'm getting is a checklist. I look at it and I say, what the heck did he think and what's he doing?
Sal?
I'd say I do a blend of what the other three physicians do. I need to prep before I walk into that exam room. So I'll review everything that happened between the last visit and the current visit, then read all the notes that I received from the three subspecialists, and then incorporate key parts of that where it seems appropriate into my progress note. And the reason why I'm doing that is it just seems to be, whether it's a local thing in Staten Island, New York City, or whatever, but the patients ask me to translate into Staten Islandese what the other physicians have done, even though they're also Staten Islanders, so there must be local dialects, in the neighborhoods that they're not familiar with. So for whatever reason, I'm asked to, can I please reinterpret what Dr. Norris, Dr. Smith, and Dr. Levin said? And so I need to put that in a note. And preparing beforehand also helps me. I kind of like flush out the thoughts about the last patient, try to get this new one in place, because there's a lot to coordinate. In the very beginning, I have to be honest with you, I've had patients say my eyes are up here type thing, so some of us know
So
that.
it seems to me, to sort of conclude on this, that there are issues with patient relationships, and you've all figured out workarounds to make it work so you don't damage the patient relationship.
Right.
That's a fair point.
But there's no time efficiency.
There's what?
You cannot be time efficient if you want to have that kind of quality interaction.
You can't, okay. So from patient relationships in the exam room, in the New England Healthcare Institute research report, it noted that patients of physicians using EHRs demonstrated greater patient medication adherence, which ultimately leads to better outcomes. For those of you who've been practicing medicine longer, and you can compare pre and post, what are your thoughts? And I'll take whoever wants to go first, because by default you admit you're as old as I am.
I think it's hogwash.
You think it's hogwash?
I think it's hogwash.
So medication adherence through electronic health records and e-prescribing, not any better. That's what you're saying?
I don't think so. I'd wonder whether they determined med adherence in the study by a doctor checking a box, patient adhering to meds. I haven't read the study. I would wonder about selection bias, which doctors are on EHRs at this point and which
Right.
aren't. But I would be very skeptical of the study.
Mike?
I disagree, actually.
Okay,
I think,
good.
and I have been pre and post, and I think that giving the patients a checkout sheet at the end of the visit that has the new prescriptions in an area that says these are the new medications for you, and continue these medications, my adherence rates are better than they were pre-EHR. And also, frankly, reminding patients that they need to go to the pharmacy and pick up the scripts that were e-prescribed. And if they don't get them, I get more calls back saying, it wasn't approved, I need a prior authorization, the pharmacy said they won't get it, it's $200, give me something else. I'm getting more of those calls back.
And I'll ask you, Bill, the same question. Considering you're in oncology, I would think this wouldn't be an issue, but I'll put forth the question as well.
Yeah, it's probably less applicable to me. I mean, my patient, I write a lot of scripts. The vast majority of the scripts that I write are narcotics. People in significant pain, they're going to pick up the script. And then other symptom management scripts, lactulate stuff for constipation, nausea, them adhering to my recommendations aren't an issue.
Okay, so we got a hogwash, it's better, not an issue. Sal, you're the tiebreaker.
Better.
Better. Okay.
And it's better, one, because we give out the notes at the end of the visit. So we attach, the diagnosis and the medication together. So why am I taking Augmentin? Why am I taking Inderal? Why am I taking this medication? Because of this. And then because we pull in, let's say, Dr. Norris's note, and we usually have the patients do like the equivalent of a brown bag when they come from the other specialists if they started on a new med. And then I could say, well, this is why he started you on this medication. And for what I find for adherence, it's the more often you tag the patient, more likely it's going to happen. So if I reinforce what Dr. Norris and Dr. Smith and Dr. Levin said, it's more likely to happen. If the script is there when they walk in through the door and do their shopping and just happen to pick up a medication, it's more likely to get picked up.
So I'm going to skip formulary and go to patient portals. We spent a great deal of time today talking about patient portals, introducing the audience to patient portals. The fact that usability means not only physician usability, but payer usability as well, or patient usability as well. So the audience understands patient portals. First question, and Sal, we'll start down with you. What information would you want to message to your patients in the portal?
One, appointment reminders. Two, demographic changes. Three, this is a pharma conference. Did you take your med? If you didn't, why?
Okay, so yet you're not going to send it out to every patient because then you'll be up as late at night as the rest of the guys doing email.
Well, no, the system does it. The system would be doing this automatically.
Okay.
That's the key. Yeah, I get an.
Okay, so you didn't, I just wanted to clarify that.
Yes.
So say it again, assuming the system does it.
Systems automatically gives them appointment reminders 1 and 3 days before the appointment. Two, we send out birthday letters, equivalent to e-letters, reminding them, please update your demographics. Three, included in that is, are you taking them as they were prescribed? And four, the fact that we can push out test results and the visit summaries is key, because not only does the patient look at it, but many of them live in a family with others, and their caregivers or significant others can review this, and it really helps with the overall adherence to not just the medication, but just the treatment recommendations.
Bob?
Patient portals is one of the things that I do really like about EMRs. So I want to share lab results, I want to share test results, potentially have patients be able to make appointments as well as have reminders for their appointments.
And so if you'd have to send those lab and test results out, someone in your office would have to do it, or you're expecting Epic to automatically send those results to the patient portal?
Well, commentary needs to be added on the lab, so it's got to be a fusion of the two. But yeah, I'd like it to be automatic, but also be able to communicate with the patient that way rather than having to have me or a nurse speak to a patient for every lab result. I mean, we currently call for every lab result, normal or abnormal.
Mike?
I'm deathly afraid of patient portals.
Okay.
The folks who come to see me have complex disorders. We don't have the straightforward labs. I can't say your cholesterol is better, your blood pressure is better. your calcium level's okay. Mine is, okay, let me interpret this high-resolution esophageal manometry and tell you if I figured out why you're still having reflux or you can't swallow. And the commentary that it would take is just to the point it's over the top and it needs a phone call, which I still don't have time to answer. But there's a level of complexity. But what I found, and it goes back to a point I wanted to make earlier, which is that I think EHRs are a very convenient way for health systems to dump more work on doctors and take it out of the hands of other medical professionals and other ancillary staff. Because now the secretary can just put it in as an Epic encounter and say, oh, patient called, we got to deal with it. And there's no assistance, because once it goes into your inbox, it's your trouble. You got to deal with it. And I think adding in a patient portal, so now they're contacting you directly on top of making phone calls, and there's probably going to be some duplication because you have enough neurotic patients that are going to do everything they can to get a hold of you. Now your inbox is going to be so full, your eyes are really going to be spinning. And so I worry a bit about that. I think that there are some ways to do that, and I actually have some computer-savvy patients that I email with to discuss their results. But one of them emailed me today, and I said, here, you have this problem. There are 2 antibiotics. You should take them for the next 2 weeks. And she just wrote back and she said, I only have 4 questions for you about that. And that's sitting in my inbox to be answered when we finish this panel. So the patient portal thing can be great for getting basic results out, but anything of any complexity that's going to trigger stuff back, it becomes very, very complex and very time-consuming.
Bill, patient portals.
What he said. As when Rich and I talked, whenever we talked a couple weeks ago, and ashamedly I didn't know much about the patient portal that supposedly exists at Penn and is supposedly utilized in our department. I actually went to everyone who I know should have an idea of what's going on, and they said the truth is you don't know too much about it because that's the way we want it right now, meaning we're grappling with the exact things that Mike talked about. So maybe some of his patients may or may not have cancer. You magnify that with a cancer patient who scrutinizes I really, when I'm in a room, I am aware of every word, after learning the hard way, of every word coming out of my mouth and the perception sitting in the other chair. So now a patient who I treated their brain for brain metastases has an MRI result sent to them. I mean, I literally would be talking people off of ledges all the time, and that's not a joke. To me, that it actually is a disservice. I mean, I think there needs to be a paternalistic component here, just as, I always make the analogy to my patients with the TB repairman. I don't know what he does. My thing is that I pick someone I trust, and then I allow them to, explain to me or to do what they're going to do in an appropriate manner. I can't reconcile what looks like it's headed our way and understand how that helps people. I think from a oncology standpoint, the thing that does make sense, rather than just seeing test results blindly, is the issue of cancer survivorship. And that actually is already being addressed, and we are utilizing a web-based approach to that at Penn, our cancer website, Oncolink, which is one of the biggest cancer information sites I think that exists, and to use it in a survivorship framework makes sense to me in terms of this is what you were treated for. These are the treatment-related risks that you will encounter for the rest of your life, as opposed to someone that didn't get radiation or didn't get chemotherapy. These are the things we're looking out for: your coronary health, lymphedema, those sorts of things, and those can be jumping off points to this is how we treat those particular problems. So to me, that's a meaningful, logical, kind of measured approach to giving people information that can be helpful to them.
So as the slide says, whether we like the portals or not, meaningful use stage 2 requires eligible professionals ensure at least 10% patients view, download, or transmit with their EHR, so it's on its way. So have I got a product for you? Oops. Oh, man. Okay, so here's a product we're working on, and it's germane to when you start a patient on a drug. Upon starting the patient on the drug, you can send to the patient portal a one-page information, personal sheet to the patient that talks about the drug you're starting on, why you're starting on it, how you should take it, in the context of where situation that you're with the patient in the EHR. For patients that you're starting on Acifex, Michael, does this work for you?
Yeah, I think it's helpful. A lot of people still, if you say this is the best drug to treat you, will say they're still willing to accept that without a whole lot of pushback. But younger patients, more savvy patients, and then some of the neurotic patients will ask for additional information. And it is nice to say, here, take this, read this sheet. I'm going to give it to you with your checkout sheet. Take a look at this. I think it's going to answer your questions for you. They're more willing to put up with less time with you after you make the treatment decision.
Bob, for Crestor, Renexa, Lovesa, I'm assuming that's all in your bailiwick. Something like this to get the patients understanding what the drug is, yet not time-consuming, allowing you to meet meaningful use, and sort of starting the relationship with the patient portal, but not doing emails at 1:30 in the morning. Why am I taking fish oil?
Yeah, I like it. I want to choose which patients I give it to. I wouldn't want it to be automatic, because there are some who don't need it, and I don't want to throw any information out there about side effects. They're just happy with my telling them this is the right thing, whereas there's others that really need more information. It's nice to give them information that we want to give them, as well as start making meaningful use.
Sal?
Yes, right now we have like a little kiosk in the exam room, and we look up stuff and we tell them they can email this information to themselves. But it would be a lot easier if, one, I could print it out if I wanted to, or two, my preference would be push it out to the portal on, depending on the patient, if they really want it or not. But then giving the patient now the opportunity to build a library of clinically relevant information for them. So if I'm starting them on Dexilent and I have this handout, if you give them a handout, what I find its lifespan is less likely to be more than 30 days. Eventually it gets lost in the house or may not even make it to the home because it's in the back seat. Portal is the way to go.
We know your patients take the meds, so we don't need something like this. But what about the patient portal to talk to the caregivers, or other survivors, or family members? Does that get back to no, too much, I don't have time for, that's why we're not using it? Or in the future, do you think there's a there?
I mean, I think one of the most fundamental issues is, who does the patient want to have access? I don't clearly understand how that's resolved. But certainly I think that's important. I mean, look, a huge component of many cancers is a genetic component. And I certainly speak to patients about that when they have it at a certain age, if there's certain malignancy where we know that first-degree relatives are at risk. Certainly, I don't treat breast cancer, but the genes that have been associated with an early breast cancer needs to be known. So I do certainly think first-degree relatives, in many instances, should be informed. The problem I have with people needing to know or trying to generate a one-page sheet about lung cancer or brain cancer or whatever is it's not apples to apples. No one that sits before me in an exam room ever is the way it's described in the book. And it's not to be, deprecating, but that's why we go to school and that's why we got trained, is to understand the subtleties of that difference. I find that it's very difficult to explain those subtleties in a quick visit, and I assume it would be less successful in a document.
So switching from patient portals to having patients come into the EHR, Harris Interactive patient portal survey said 85 of the physician respondents are in favor of patients updating demographics, family medical history, medicines, and allergies. We sort of touched on this. Are you guys okay if you're I see Bob making a face there. Are you okay if the Or no,
I'm actually thinking about that one.
Okay.
There's parts of it I agreed with, like the demographics. On the medication list, particularly on something like Epic, where you have a lot of different physicians, and sometimes there is some controversy about the med list. I'm not sure if I want one more person, the patient, who may or may not be sophisticated adjusting it. So I have to think about that one.
Mike?
For my patient population, I think it would be fine. I think they're actually sometimes more accurate than my medical assistants in giving the drugs, and I actually find myself going back over the med list myself to fix the errors that were put in 5 minutes before. So I would be great with that, although family medical history is tough because the terms that are in there, at least in the current form, are very medical terms and terms that patients wouldn't know. And so you'd have to make it a patient-friendly language. I mean, doctors in general are terrible at speaking in English, as we've alluded to earlier. Well, patients don't know medical language either, and the EHR is kind of written in medicalese. So you'd have to come up with a translation system that goes well beyond what we have right now to make it patient-friendly to do that data entry.
Is there room for patients to input in their EHR in your practice?
Yeah, I mean, certainly there's I think given that I'm a part of a large institution, I think that that's going to be a decision made higher up than me. But what I was thinking I would like to see is I would like to see maybe a parallel process going on. I do agree with these guys there. If you have a patient that is with it, I mean, many people, it's unbelievably impressive, some patients, that they know to the day things that happened 20 years ago. I have trouble sometimes last week with myself, but some patients I find the most help out of anyone, much more so than any doctor. Other people, they know nothing. So I think it can only help. I certainly wouldn't want them to manipulate a record that's been generated by different physicians. But I think that certainly you would be able to glean some helpful information if there was an area for them to update on their own.
I'm going to completely switch gears and give me a couple more minutes on one more subject, and then we'll wrap up here because I know we're going over. And we talked about this in the market research study, and that was the subject of couponing and affording physicians the ability to see coupons or other discounts in the EHR for their patients. So Sal, I'll start with you. What you're thinking about couponing, seeing that information in the EHR? Have you tried sending coupons with e-prescribing? Does it work? I know his get lost, but we'll start down there with you.
I don't have the opportunity right now to send coupons.
Do you see them in your EHR?
No,
Okay, so that's not even there.
not even an issue. But it's not uncommon for me if I start someone on iron or narcotic, which I don't prescribe too often, but certainly iron supplements for my patients with anemia. They almost always need Colace or some other stool softener to go with it. And for women, when I start them on certain antibiotics, I almost inevitably tell them to go to the local store and get some Greek yogurt to avoid getting some complications, benign, from the antibiotic. So the idea of matching an over-the-counter type medication or even a prescription medication to the main medication to treat a known consequence makes sense to me. It's only
So that's a companion therapy OTC because there's a known side effect of taking a drug. What about just if you had the ability to have a Crestor coupon right along with the script right out of the gate, would you be?
That'd be incredibly good.
Bob?
Yeah, I agree. I think on part one of the question, the brand necessary drug, the Crestor example, yes, if I've already chosen that that's what I'm going to give the patient, to be able to pull up a coupon, print it out, email it, whatever, is great. As far as the second part, or what I've made the second part, the add-on medication, the add-on over-the-counter, I think there's situations where that could be helpful, such as when you're using iron or a narcotic, to be able to give them a coupon for Colace or some other laxative. But as a physician, I would worry about it being over the top in some situations, and I think that would be the downside of it. If one were to prescribe prednisone and a coupon then came up for an H2 blocker, I click no, and then it comes up for a PPI, I click no, then it clicks up for calcium, I click no, and then a sleeper. I click no. It could actually get a little burdensome if there was really too much of this, and if it was maybe too lucrative.
So if a branded script was offering a coupon to get the patient started, that would work for you. If you could ride it along with the script to the drugstore, I'm asking, sort of, that would work as well. You mentioned something. You'd be willing to print the coupon out in your office for the patient?
Yeah, I would have it print at the checkout desk, and at least in my current scenario.
Sal, would you print?
99% of the time I don't have to because I send stuff through SureScript, so I would want it to go out electronically. The less trees killed, the better.
Well, the reason I ask that is I have some friends who are sole practitioners, Jay, and he doesn't like to print because he says, who's going to pay for my paper? Who's going to pay for my ink toner? Et cetera, et cetera. Now, I know these three guys, that's why I asked that. You three guys are all employees, so to speak. So the hospital system's paying for it. But the single practitioner, I've heard that before. Coupons, Michael.
So, yes, and I think that my biggest issue right now is I prescribe a lot of proton pump inhibitors because of the complex reflux patients that I see. And my biggest deficit with EHRs right now is not knowing what the active formulary of that patient with that insurance in my room can get without having to go through the prior authorization process, or what drugs they have to fail that I have to document before they get the one I want approved. And when they get a branded one that's got a high copay, if there's a coupon that's available for that drug that's sitting in a locked cabinet down the hall because we got rid of samples and we might have some left over, who knows if I remember rushing around at the end of the visit to give it to the patient. So, in a dream world, I would love to know which PPI I could prescribe without having to go through the rigmarole of prior authorization and all that documentation that you have to do after the visit. And I would love to be able to have maybe on the after visit summary, an extra couple lines saying a coupon for this drug was also sent to the pharmacy for you. And I don't really mind if it's an extra page or not, but, and I do know what our overhead is. But I think it helps the patient and ultimately probably helps compliance when they don't have a $150 copay, and maybe it goes down to $20, they do better, and then that's one less hospitalization, and that's better for everybody.
I don't know if coupons are applicable in your practice, but let's go companion therapy. Narcotics, constipated, would a OTC coupon work for you, Bill?
Yeah, with the right presentation, it would. If it saves people money. The narcotics themselves are extraordinarily expensive, particularly when I want to use a time release. That's the big one where I run into a jam a lot of times with insurance. I can always write immediate release morphine or something like that, but with the time releases, I absolutely, in this day and age, if it meant the difference between getting what I wanted and someone not affording it, and a lot of my patients wouldn't be able to afford it, I would be interested. But certainly in terms of the symptom management, constipation, those things, absolutely also.
I specifically didn't go to formulary today because that's a whole rat's nest that we'd be up here all day. Mary from Pfizer, if she's still here, she mentioned it, that's a challenge unto itself. We had dinner last night, so I recognize, and the EHRs recognize, they don't have formulary fixed. And I think they got the clinical stuff right, but maybe they didn't get the formulary stuff right. I know you all stayed late, and we appreciate it. We'd be happy to take a question or two if anybody's got one. If you don't, I understand because it is late, but does anybody have a question for the docs that they'd like to ask? They'd rather hit the wine and cheese. So I'm going to thank all you guys for coming down and giving us an hour from your practice.